Okay, so good morning, everyone. This is Leah D'Souza from the Teach Project, and before we begin the webinar, I'm going to ask that those people who are on the teleconference would please mute their line by pressing *1. We need to make sure that we avoid any feedback, and right now there's a lot of feedback. So before we begin, I am going to mute those on the teleconference using *5. That way everybody is muted. We can make sure that you are hearing us from our end. And if you have any questions, please feel free to type in the chat box for those who are following along through the webinar.
Conference is now in silent mode. All
Okay.
participants are muted. Press *1 to unmute your line.
So today we're going to begin our 9th session for the Lunch and Learn series, and that is the highly complex client. Today we have with us faculty member Rebekah Barrett. Hello. Now, before we begin and we let Rebekah take over, I have a few housekeeping announcements. First of all, please ensure that you have registered for this webinar. And for those of you who are signing up as a group, it is vital that you email Eleanor Ball-Banting, and her email address is listed on the screen, immediately following the webinar with the list of participants. That way we ensure that everybody who has attended the webinar receives their letter of completion. Without this list of participants, Elle cannot follow through with that request. Again, the Learning Assessment 1 has followed the registration, and a link to Learning Assessment 2 will be sent by email following this webinar. Now again, as a reminder, both the learning assessments are required for the letter of completion. As a reminder, we'd like to tell you that it's important to log in using your first and your last name rather than guessed. We know many of you have actually already done that, so great job. And if your audio on the computer is not working, please join in via the teleconference using the number seen below with the participant code. Again, if your computer is working, you don't have to join in through teleconference. It's just redundant. So these webinars are being live tweeted on Twitter, and you can follow us at the Twitter sign seen below, and you can see the hashtags following through as we go. Now, the Teach curriculums and slides have been developed and are compiled with funding from the Government of Ontario, specifically Ministry of Health and Long-Term Care. And the content is primarily based on the following sources seen on the screen. And as a disclaimer, we'd like to remind you that these materials and all of the verbal presentation and any discussion that occurs during the webinars are only set out as general principles and approaches, but do not replace the need for individualized clinical assessment and treatment plans. Okay, so for those of you who do get the little joke, we'd like to find out what you really want in the coming 2014 and 2015 years. So in order to do so, we would like to ask that you fill out a Lunch and Learn and Community of Practice Needs Assessment by following that link. And if you would be so kind as to complete that before January 23rd at 4 p.m. So we will deactivate the survey at that point. So it is relatively soon, and please make sure that you take the time to complete that after the webinar as well. Okay, so a little bit about our faculty speaker today. Rebekah is a registered nurse, and she's currently working on her Master's of Nursing through Athabasca University in order to help her prepare to become a primary care nurse practitioner. Now, Rebekah has had much experience working in various departments, such as emergency nursing at the Hospital for Sick Kids, and she's also worked at Tattle Creek Family Health Team. Rebekah has been actively involved with Teach since 2010, so she is a long-term member, and we welcome her today. These are just the disclosures for Rebekah. And with that, I'll hand it over to Rebekah to begin.
All right, thank you so much, everyone. I'm seeing everybody logging in and saying where you're from, and it's really a pleasure to connect with you from, it looks like, all over the country today. It's very exciting to be here at the Teach office in Toronto and to be able to connect with all of you. So thank you for coming. And for those of you who had originally registered for the webinar, signed up on for December 18th, I do apologize for my illness and the need to reschedule. So I thank you for your flexibility and for joining us today. So our learning objectives for today's webinar is to apply a framework for screening, assessment, and intervention with specific and interacting risk factors. We're going to integrate motivational interviewing strategies such as agenda setting, elicit, provide, elicit, and action planning into clinical practice and feasibly applying those in specific case examples. And we're going to talk about motivating clients to build their self-efficacy and become positive self-managers. So I'm going to briefly introduce the case study, which we will be coming back to at the end of the webinar. This case study, his name is Jack. He's a 68-year-old client with a long history of tobacco use, alcohol, and other drug use. Depression, osteoporosis, COPD, hyperlipidemia, unhealthy diet, and sedentary lifestyle. Now, when I come across a client like Jack, this is understandably overwhelming. It's really hard to know where to begin, where to start, what the priorities might be. And I'm not here to tell you that there's one way to do it. Of course, we all have our unique practice approaches, our unique practice resources, and our own personal interests that we like to work on, especially with clients, our own specialties. But I'm here to present some lessons that I've learned in my work with chronic disease prevention and screening and work with people throughout all age groups. So when I first began working in primary care back in 2009, when I would see patients like Jack, I just felt really overwhelmed. And I'm going to be a bit vulnerable here and tell you, just exactly the way I felt when I came across, when patients like Jack would enter my room and I would meet with them, and I have to attribute this dish rag effect analogy to one of the social workers that I worked with at the Tattle Creek Family Health Team. I remember walking into her office and just feeling completely, used up and limp and really feeling like there was nothing I could do to help these people. And I was working so hard and just really didn't feel like I was going anywhere. So I would either come away from working with people like Jack feeling like this, or completely frustrated that, I had lack of resources to help, make a real difference in these clients, that I was working so hard and not seeming to really see any results. And also, quite honestly, I was frustrated that some of these clients were quite resistant to change. And so, being from my start in my nursing career was in a pretty intense acute care setting, and from which I burnt out fairly quickly. I was suffering probably burnout even within a year and a half into my career. And so I was starting to notice the same symptoms in the way I was approaching and dealing with clients like Jack, that I was starting to feel those symptoms of burnout, feeling overwhelmed and feeling very frustrated. So I realized that I really needed to change the way I was looking at things. I started working in primary care, and I fell in love with working with primary care. And so I really wanted to be able to stay and be productive and feel like I was making a difference in this field of healthcare. And so this quote really stuck with me, that if you change the way you look at things, the things you look at change. So I needed a new approach. And if you remember these stereograms from, I don't know, was it the 80s, the 90s, once you start to look at them and look at them and look at them, and then finally when the puzzle is revealed, it's hard to go back and see it as an indiscriminate, picture. And that's what's happened to me in my paradigm of how I approach complex clients in primary care. I've had a major paradigm shift in two main areas. So the first area was approaching things from an integrated chronic disease prevention and health promotion manner. The second was around patient self-management. Now, looking at an integrated chronic disease prevention and health promotion approach really flips things on its head in the way that we have been trained as health professionals to assess our clients or to deal with certain chronic disease. So can they see my cursor here? Okay, so if we look at the typically the way we've been trained as health professionals is to look at things in a disease-focused manner, right? So if someone has hypertension, we focus right in on that, or cardiovascular disease, diabetes, cancer, and then we tend to go backwards and look at the risk factors for those specific chronic diseases. And certainly the way that we're trained and in the clinical practice guidelines that we access to be able to help us manage patients with these types of chronic diseases, they encourage that model, right? We don't necessarily look at things in an integrated fashion. So if we actually then think about secondary prevention, a lot of us are quick to, recommend screening and, doing checks for high blood pressure and tests for cholesterol, etc. But really what we want to do is start targeting things at these modifiable behavior risk factors first and spending more attention and more time on addressing the prevention and health promotion factors such as smoking, physical activity, alcohol, and other substance use, nutrition, and mental health. So changing that approach and kind of flipping everything on its head and focusing on these modifiable risk factors is really was a big paradigm shift for me. The other paradigm shift was around patient self-management. And this really challenged my belief in the way I look at two areas. First being the healthcare system, and secondly being the healthcare professional and patient relationships and our roles. So what we're facing now in Ontario and across the country is we're littered with chronic disease, right? We know that the majority of people in middle age have at least one, if not more, chronic disease. And this is what we are challenged with as healthcare professionals right now. However, our traditional healthcare model really, as I'd said before, looks at these diseases in isolation. And I think that's to be honest with you, that's a reasonable approach when we're overwhelmed. I mean, this picture is very overwhelming for all of us. And so it's natural for us to want to break things down into easier bite-sized pieces that we can start to make changes with. However, this isn't necessarily a good approach in the challenges that we're facing in healthcare today. So our traditional healthcare model is historically designed to assess, treat, and cure acute illnesses or injuries. So this works really well in someone who's broken their leg. They have an acute injury, we know why it happened, we know what we need to do with it. But when it comes to chronic diseases, our traditional healthcare system has not well served those with chronic disease, which have, gradual onset, many causes, lifelong duration, uncertain or lengthy diagnoses where people need to visit perhaps multiple specialists and undergo several tests. It has periods of exacerbation and remission, and necessarily treatment does not equal a cure. The other thing around our traditional healthcare model is the difference in our belief about our roles and how we've been trained. Now, I'll just give people an opportunity to type in. This to me, this picture depicts the traditional client and healthcare professional roles. How does this picture speak to you? What do you think this depicts in terms of the traditional roles? Right, so Andrea writes that there's obviously a hierarchy, even just in the picture of the power imbalance. Eli says, Natasha rightly says the practitioner appears to be the authority or is the expert. There's a superiority of the healthcare professional as they're standing above the patient. Now, let's talk about the patient. What do you, does it look like she's bringing anything to the table here? Right, so we've got Dana nicely says, you know, the client looks as if they're looking to the doctor to help her. It doesn't really look like the patient is bringing any of their own expertise or knowledge to the table. You know, in this traditional model, as you've all said, the healthcare professional is expected to be the expert, and the patient is really expected to comply. Now, changing our paradigm in this manner switches our thinking in terms of having a partnership with our clients. So it implies that while professionals are experts about diseases, patients are experts about their own lives. We're there to guide our patients, to acknowledge the expertise that they have and the desires and goals that they bring to the table, and they're to help them become positive self-managers. So rather than just being a receiver of care and compliant with the healthcare professional recommendations, we're here to support the patient in an expanded role. So the patient defines their own problems. They're the primary decision maker, not the primary care provider or the healthcare provider. The patient accepts the responsibility to manage their own condition, solves their own problems with the information that they can seek from various sources, actively participates in their treatment, monitors their symptoms, and is able to report them accurately to their team. And they're the ones that are managing these symptoms on a day-to-day basis. So when we look at the patient self-management model, healthcare professionals need to acknowledge that the patient's role has, you know, three pretty major tasks when they're dealing with chronic illness. Not only are they working to manage the illness on a day-to-day basis, you can imagine whether that involves medications, injections, changes to their diet, physical activity, et cetera, but number two, they also need to work on continuing their day-to-day life. So just because they have a chronic illness doesn't mean that their day-to-day life stops. They still need to take care of responsibilities for themselves, their family, friends, work, what have you. And I think another important aspect, which we don't necessarily always acknowledge, is the work of managing the emotions of having a chronic disease or illness. So working through what that diagnosis means, how it can change their life, and how they're going to accomplish these other two tasks that we've stated. So we want to encourage our patients to become positive self-managers. So when I think of a manager, these are the thoughts that come to mind, right? That the manager is in control, they're the ones in charge with the most responsibility, they're the decision maker, they're the ones that gets things done. And you know, when you think about it, one can't not manage. Everyone has a management style. It doesn't necessarily mean it's positive, but there is a management style. So if I can read a quote from the Living a Healthy Life with Chronic Conditions, from the patient self-management textbook out of the Stanford model, they were saying there's no way you can avoid managing a chronic condition. If you do nothing but suffer, that is a management style. If you only take medication, that's another management style. But if you choose to be a positive self-manager and undergo all the best treatments that healthcare professionals have to offer, along with being proactive in your day-to-day management, this will lead you to a healthy life. So we really want to help our patients become positive self-managers. one way that I think that we can help our patients, become positive self-managers is that we need to give up feeling responsible for our patients and become responsible to them. This was a quote that really stood out for me, and I'll give you an example. I think a lot of health professionals have difficulty with giving up that responsibility. For example, when I was working at the family health team here in Toronto, we regularly ran a complex care clinic where a primary care provider would invite a client and their family or their primary caregivers at home or partner to come in and meet with various health professionals that we had on the team. So nurses, pharmacists, dietitians, their primary care provider, psychiatry, social work, internal medicine. We would have all those people in the room to be able to try and work through some of the complex issues that we're facing these clients. And the complex care clinic would initially start out with a presentation from the primary care provider, so kind of highlighting the issues going on with this particular patient. And I remember at one clinic, as the primary care provider was sharing the case story, all of us, you could just feel the energy in the room, just kind of, we were feeling so overwhelmed. And, one person put up their hand and said, well, I know, all you have to do is just move in with the patient and the family, and that's what's going to solve all their problems. And, some of us kind of giggled a little bit, and obviously that wasn't realistic. But, on reflection of that moment, I was thinking what a disservice that would actually be, because rather than helping the client and the family learn to manage their issues and supporting them in that, we would really be taking over responsibility, and we would be doing them a disservice by not encouraging them to manage their issues on their own with our assistance. So instead, our role becomes that of a coach, a listener, a cheerleader, which I've been called several times. I've also been called a dragon by my patients. A teacher, consultant. We're there to help our clients interpret their symptoms. We're there as a resource person. We're there to offer suggestions based on our expertise. And we're there to empower our clients. So all of that is a pretty tall order, right? And putting it all together in daily practice takes a lot of time and energy. And I wanted to give you an example of how to put this all together, because I was fortunate to be able to participate in a randomized control trial study back in 2010, 2011, and the results have actually just been published in November. So in a moment, I will post the reference for the article, because it's a pretty interesting study that was done. So the study involved 4 primary care teams, so 4 in Edmonton and 4 in Toronto. And part of the study that I was involved in was this prevention practitioner intervention. So that when I was involved in the study, I would wear my prevention practitioner hat, and I would meet with clients for 30 to 60 minutes for an initial prevention and screening visit. And that was the intervention that I was involved in the study. Now, I think although 30 to 60 minutes might sound like a very generous amount of time for many of us working in primary care, I want to tell you about the role that I was involved in, because there was actually a lot to cover during that visit. So during the prevention practitioner prevention visit, within that 30 to 60 minutes, we were expected to go through not only informed consent for the study, but also to discuss the patient's family history, to discuss the primary screening maneuvers for chronic disease such as diabetes, cardiovascular disease, and cancer screening, and also to discuss all of the lifestyle or modifiable risk factors involved in those. So such as I already had said, family history we discussed, but also alcohol, mental health, smoking, nutrition, physical activity. We were also expected to measure blood pressure, height, weight, and waist circumference during that visit as well. So it was a lot packed into one. So that's why I wanted to bring it to you as an example of how to put this all together and some of the tools that we used. So the role of the prevention practitioner, I kind of, analyze it as the air traffic controller of your health. So I would always say, I'm not the one flying the plane. You're the captain of this vehicle. I'm here to function as an advisory, within advisory capacity. I'm here to help, advise you of a safe, achievable flight plan, and to renegotiate that plan if changes should arise. So, as I had said, there were a lot of expectations out of this 30 to 60-minute visit. One of the things we really had to do within the study is make the most out of our time-limited interactions with our clients. So one of my most favorite questions to ask whenever I see a client, within the study, outside of the study, now during my nurse practitioner, clinical placements, is what are you hoping to get out of our time today? This is an opportunity to use motivational interviewing, strategies such as agenda setting. So we can, during this role and clarification of expectations, we can hear where the priorities for the clients are. We can listen for where they're at in terms of stage of change. We can try and listen for change talk, for quick wins, and where the patients are the most motivated. This also, on a practical standpoint, it saves us time and gives the client a chance to buy in. So one of the tools that we used in the Better study to help us with this was what we ended up calling and naming it the bubble diagram. So I used this as a map for my visits, saying, we're going to focus on our visit today on the prevention screening of cancer, diabetes, and heart disease, and all the things that can either be protective or can actually increase your risk for developing these diseases. When I originally was seeing a woman who was a 48-year-old woman, I had asked her, again, what out of, seeing what we're going to be hoping to discuss today, what would be your priorities? And she had said, well, I really wanted to learn how to better manage my depression, and I also want to lose weight. So in my kind of previous mindset, I would probably jump right into the depression, right? Talk about why, when she was diagnosed, what medication she's taking, and go into all of that. Or I would jump into weight loss. But with this integrated chronic disease and health promotion standpoint, I wanted to take a step back and asked her permission if we can look at some of these other risk factors as well. So during that discussion, we learned that using this model, I asked her about the physical activity and her alcohol use. And she told me that she usually had 2 glasses of wine every evening with dinner, and that she goes for walks occasionally, but generally has a pretty sedentary lifestyle. So this was an opportunity to use another motivational interviewing strategy called elicit, provide, elicit. So I asked her, how do you think your regular alcohol consumption affects your depression? Well, then this was an opportunity to discuss how her alcohol was actually a depressant and can potentially impact the efficacy of the antidepressant medication that she was already on. Also, alcohol has a lot of calories. I wonder how that might affect your goals around weight loss. Also, using an elicit, provide, elicit statement was saying something like, would it be helpful if I shared with you some ways that physical activity might be helpful with your depression and weight loss? So the physical activity, as we know, would stimulate natural endorphins and help her burn calories to lose weight. So this was a good example of how my old way of thinking of kind of diving into the depression or diving into the weight loss and really focusing on those 2 areas how I really would have missed a lot in terms of stepping back and having a look at those other modifiable risk factors and how these can actually make a big difference. Yet we were still paying attention to her priorities. Okay, so let's take these approaches and apply them to another case. So after we've got these approaches, we're seeing that we've got this information with this woman. Sorry, we'll go back to her for just a moment. So once we've seen that, okay, we're using the elicit, provide, elicit, we've set the agenda. Now what do? So in terms of let's integrate the self-management approach. We want to support our patients to become positive self-managers and to build their self-efficacy. So the self-efficacy piece is really important when we're helping our clients for change. Self-efficacy is the confidence that one can carry out a behavior necessary to reach a desired goal. Goals and goal setting are important in developing self-efficacy and in learning the skills of self-management. Now, many of us have heard of SMART goals, right? They're specific, they're measurable, they're attainable, they're realistic, and they're time-framed. We've all heard of the SMART goal philosophy, and I entirely agree. So when I asked this woman about her, what kind of goals she would want to make for change, she said, I would like to lose 20 pounds in 6 months. Now, I believe that this qualified under all the requirements for a SMART goal. It was specific, it was measurable, it was doable, and it certainly had a certain time frame. However, is that going to be helpful for her stepping out the door this week, next week? How is that going? What are the steps she's going to take to reach that SMART goal? So this is where action planning comes in. These are the small steps that are involved in reaching the goal of losing 20 pounds in 6 months. So when I think of an action plan, something that my dad taught me a long time ago when I was a young girl and I would be overwhelmed by schoolwork or my chores or what have you. And I tend to see the larger picture and get overwhelmed by it. And so I can, this is very applicable to me in my personal life as well. So the action plan, when I think of creating an action plan for even myself, I hear my dad's voice in my head that says, Rebekah, just do the next thing. So I tend to use that with myself and with clients. What would be the next thing? What would be the next step for you to help you reach that goal of losing 20 pounds in 6 months? So together with this woman, we broke it down to something a lot smaller, something that she could do this week, something that she could probably sustain over the next few weeks, and something that she wants to do. That was really important. It's not something that I was telling her to do. It's something that she wanted to do. So her action plan was she wanted to go for a 30-minute walk twice this week on Tuesday and Thursday. And the other really important thing about action planning is measuring the confidence. So I'll get to that in a moment. So again, really key components of an action plan is that it's something that the client wants to do. It comes from the client. It should be something short, this week, next week, and something realistic. So let's get back to the confidence. Whenever you're making an action plan with clients, it's important to measure their confidence to see how doable this actually is. So for her, when she had made the action plan of going for a walk twice this week for 30 minutes on Tuesdays and Thursdays, and I said, how doable is that? How do you feel, how confident are you that you're going to be able to follow through with that plan? And on a scale of 10, 1 or 0 is absolutely no confidence. I'm not going to be able to do it. 10 out of 10 is totally confident. And generally in practice, 7 is the magic number. If the patient, so she had actually rated her confidence as 7.5 out of 10, which I accepted. I thought, okay, that's great. If her confidence was somewhere around the 3 or 4 mark, that's an opportunity to explore what the barriers would be and how we can maybe work through some of those barriers or adjust the action plan to make it something that they can achieve more easily. Again, because we want to make sure that the action plan is doable, because this will help to build the self-efficacy for change. So I've got a couple questions here about why 7 is the magic number in terms of confidence. So I'll try and highlight that in this next activity. So we're going to work through this together. This is based on a client that I've seen in real life. He's a 38-year-old male patient, and he was referred to me at the family health team because his doctor had noted he had an elevated blood pressure at his last recent visit. And when I, reviewed the chart, he had been smoking for several years. He was Hep C positive, had a history of IV substance use. The 30-minute appointment was booked, which, is generous in many of our circumstances. The patient was 5 minutes late, so already we're on a bit of a time crunch. Question 1. This is a complex patient. Where would you start with him? Realistically, what would you do if you were me and he was walking into your office? What would you start with? So A, would you dive into an assessment and check his blood pressure? B, use agenda setting technique? C, advise him to stop smoking right away? Or D, make an action plan? Good. So most of you are saying B, right? This is an opportunity to see where the patient's priority is, use an agenda setting technique such as, what are your expectations out of coming here today? So using your agenda setting techniques, you found out that the client says he's here because his doctor told him his blood pressure was too high. He's also thinking about quitting smoking, so he'd like some information about that. And he is currently cutting down on his drinking to prepare for his Hep C treatment. So, he's coming up for his treatment, so he thinks it's probably a good time to cut down on his drinking. What would be the next thing that you would do? Would you ask permission to check his blood pressure, advise him to stop smoking, make an action plan, tell the patient he should stop drinking? Okay, so a little bit more mixed response on this. And you know what? This is up for a debate. I don't think there's one real clear answer, but I do put this question up. My personal choice would be A, ask permission to check his blood pressure. And the reason why is because I think even though, it's important to acknowledge why he's here and to acknowledge his agenda, but also I think it's important to acknowledge and be honest with our agenda when we come to when we bring what we bring to a client visit. So, but it doesn't mean that we just dive into our own agenda. So for him, I completely acknowledged. I said, you know what? These are all great things, and I want to make sure that we touch on these things today. Let's talk about your smoking. Let's talk about the drinking. But also, one of the reasons why you were scheduled this appointment is because your doctor noticed that your blood pressure was high. And, smoking and drinking can actually make a big difference in terms of your blood pressure. So is it okay if I check your blood pressure today? I think asking permission is really important. Okay, the blood pressure at that visit is 146/98. Some of you who've worked with hypertensive clients before, you'll know that this blood pressure is within the Canadian hypertension guidelines, above guidelines, or below. Right, we know that this person has high blood pressure today. Okay, so what are we going to do now? Are we going to ask the doctor to prescribe antihypertensives? Are we going to use elicit, provide, elicit techniques to determine his knowledge about blood pressure? Or just tell him the blood pressure is way too high and you need to lose weight? Good. Easy question. All of you are saying B. So this is another opportunity to use our motivational interviewing techniques, something like elicit, provide, elicit. This is an excellent way to assess your client's knowledge, and it's an opportunity to clarify your client's understanding and response to the information that you've given. So It can be as simple as asking, can you tell me what you know about blood pressure? Or would it be helpful to know what blood pressure means? I don't know how many times I've seen clients, such as this young man, who have said, I just know blood pressure is bad, or have been on antihypertension medication for years, decades sometimes, and don't know what blood pressure means or why they're taking this medication or how it works. So I love using those general questions, those elicit, provide, elicit opportunities, just saying, tell me what you know about blood pressure. This opens up the conversation for a chronic disease prevention approach in that integrated way. So then if someone, another way that I like to ask is, what do you think might be affecting your blood pressure? That's where we can start to get at these other things. So the modifiable risk factors, the smoking, physical activity, alcohol, nutrition, etc. So we've reviewed the modifiable risk factors that may be affecting this client's blood pressure, and he's ready to make an action plan. His action plan should be about A, quitting smoking, B, losing weight, C, exercising more, or whichever change he wants to make. Good, another easy question for you guys. Okay, so based on his previous, stated priorities, he said, wow, I didn't realize my alcohol was, not only affecting my liver, but also affecting my blood pressure. I want to stop drinking alcohol tomorrow. That's my action plan. What would you do next? Many of you, good, are saying B, you check his confidence level. So when I asked him, and again, these are these things that I've practiced in the mirror several times to try and make it not sound artificial. It sounds funny to say, let's measure your confidence. On a scale of 0 to 10, how confident are you that you could follow through on this action plan? So however you practice it or say it to make it feel natural to you in an interaction, please do so that, because I think these tools are only as good as how comfortable you are in using them. So please practice them with your colleagues, with your clients, with your partners, your family, however, to try and make it feel natural for you. So for him, I was saying, wow, okay, that's a bold action plan. Let's check to see how, confident you feel that you can follow through with this. So he measured his confidence as only 3 out of 10. Someone, Jennifer, has a great question there. So using the skill is a great opportunity to explore why their confidence is either really high or really low. So Jennifer said, why is it a 3 and not a 0? Well, in this case, he said, well, I quit using IV drugs before. So I know that when I put my mind to something, I can do it. But, drinking has been a part of my life for a really long time, and I'm not feeling as comfortable or confident in doing that. So thank you, Jennifer, for bringing that up. I think it's really important to explore a patient's why they've chosen that certain number of their confidence level. So where do we want his confidence to be when we're making an action plan? Good. Most of you are saying 7. So 7 is the magic number. Again, and that's based on the literature coming out of from the Stanford model, the chronic disease prevention screening and self-management literature. So what do you think? One of the things when a client has a low confidence, one of the questions I like to say is, what do you think we could change about the action plan to make it more feasible or more doable for you? So when we talked about this, the client was saying, actually, it's been a really long time since I had a non-drinking day. So his new action plan was, I won't drink any alcohol on Monday and Wednesday this week. And when we explored his confidence, it was 8 out of 10. How would you proceed? So we support his action plan, commend client for making this change, and arrange for follow-up, or all of the above. Good. We're all saying D, most of us, and that's terrific. One of the most important things in this is the arranging for follow-up. So that can be something as simple as, with this client, would it be okay if I called you in a week to find out how you're doing with this? And most clients will actually be taken aback. I've never had somebody say no. I don't want you to follow up with me. Most clients will be very happy that you've offered to follow up with them. Okay, so for this particular client, this approach really worked for him and in countless others that I've worked with. So on follow-up, he had reduced his drinking significantly. He reduced his smoking with NRT through the STOP study. If you're not involved and have the opportunity to be a part of the STOP study through CAMH, I do encourage you to be a champion at your workplace and try and get involved with that. Being able to offer your NRT to clients at no cost to them is really an amazing opportunity and intervention for smoking cessation. This client increased his physical activity and find that it helped reduce his cravings for alcohol and for smoking, and his blood pressure came down to 126/82. So since using these approaches, so the integrated chronic disease prevention and screening, looking for those risk factors, taking that broader look at risk factors with all clients, and not just those with chronic disease, but also with everyone to help them, help us prevent chronic disease. I'm having a lot less of these days where I'm feeling like a dishrag or very frustrated, and it's really renewed my love for primary care, renewed my love for nursing, and for working with complex clients. So I'm hoping that you'll share the same. We have, it looks like 13 minutes left before 1 o'clock comes. So I'll take a couple questions right now. We'll take a couple minutes for that before we dive into the main case study for this presentation. We'll go back into Jack in a moment. Thanks, Eleanor, for posting the link to the STOP study information. I'm also going to take this opportunity, just while people are typing in questions, to put that link for the Better Study publication. And actually, the study is available for free on the web, so I'll give you the link here. Okay, Richard, thanks for your question. How do you make sure that he continues to keep up with the positive change? I think that really depends on your practice setting. So I had the opportunity to see this patient several times over several follow-up visits. And you know what, to be completely honest with you, there was ebbs and flows, and sometimes he relapsed with his smoking and then quit again. And so I think that's a realistic view, that this is, as I said at the beginning, this isn't the one way and the right way. We need to make sure that we have reasonable expectations in terms of change with our clients and management of chronic disease. But I think if you have the opportunity to do close follow-up with your clients, I think that can really make all the difference in checking in with them regularly. Okay, so not too many other questions here. Let's jump into the case study. How many follow-up sessions were held with this client from Grace? As I said, I've seen this client several times over a period of about 6 months. Okay, so let's jump into Jack, because we don't have much time left, only 10 minutes. So Jack began abusing substances at a very early age. He grew up in a mining town in Northern Ontario with his father, who was an abusive man with severe alcohol dependence, and his mother, who suffered from anxiety. His father had difficulty staying employed, which meant that the family often had trouble making ends meet. Jack began smoking at age 7 and started drinking at age 10. Eventually dropping out of school, he moved to Sudbury to find work at 15. Jack began a long career of using cocaine in his mid-20s, in addition to other substances, but over the last 8 years, he's stopped using. Jack still drinks and smokes tobacco and has suffered from severe chronic depression for over 40 years. He also has a myriad of health problems due to his prolonged use of substances, poor nutrition, and sedentary lifestyle, including osteoporosis, COPD, and hyperlipidemia. Jack has recently tried to reconnect with his 28-year-old son, and he's interested in getting healthy, but finds it's difficult to stay motivated as he continues to have feelings of worthlessness, poor appetite, poor concentration, loss of interest in things and activities, feeling irritable, and feeling sad. He denies suicidal ideation at this time. So let's start here with question number 1. What are the central issues in this case? I'll go back to the slide with the case study on it. So what are the central issues that you would see? Okay, so Joanne's saying depression and substance use for sure. Alcohol dependence, mental health, physical health, lots of chronic disease. Good. Let's think about, remember that bubble diagram that I had showed earlier? Let's think, and the integrated chronic disease, what are the modifiable risk factors, some of the issues there? So not necessarily focusing on the diagnoses that he has, but on the risk factors. Good. So Susan's pointed out poor nutrition, sedentary lifestyle, smoking, alcohol, mental health. Very important. Someone's brought up the history of trauma. Good. Okay. So a lot of the main issues have been covered here. And again, when we're thinking of these issues, we want to think about this environment behavior biology. So someone has talked about, he started using alcohol and smoking at a really early age. Certainly that is going to affect his development over time. And the family history of mental health as well. Okay, so let's talk about his barriers to change. And again, we can think of barriers in that environment behavior biology model. Good, so lots of people stating he's got a lack of motivation, his mental health, depression is certainly a barrier, feelings of worthlessness. Stacy says, he's got a history of maladaptive coping strategies. In fact, it seems like he was never given the opportunity to learn effective coping strategies. So that's a really important point. Self-efficacy, low confidence. Someone saying his medical problems are a significant barrier as well. Another barrier that I've become a lot more involved in my a lot more aware of due to some of the reading that I've been doing in my NP program is health literacy. So Jack, given that he dropped out of school and he doesn't have an extensive education at all, so literacy would probably be something that I'd want to think about for this case as well. Okay, so let's get down to the nitty-gritty. If Jack came to see you, realistically, where would you start? What would be your opening line? Whoop. Nope, we're not there yet. What would be your opening line for Jack? Good. So Stacy said, what are you hoping to get from today? Some people are saying, what are you hoping to get from our meeting today? What are you hoping to get out of our time together today? Why are you here to see me? I think those are great opening lines, ones that I've used personally and will do for a long time. And I think that's really important around that agenda setting, right? Seeing where the client's priority is. Good. Someone, Yvonne, saying, you know, if you were to make a goal out of our meeting today, what would it be? How would you integrate interventions addressing this patient's tobacco use as well as interventions targeting other risk factors? So assuming that Jack, you know, is wanting to cut down on his smoking or quitting smoking and keeping in mind all of the other issues that are going on for him, what interventions would you recommend that would, you know, affect several areas? Good. So some people are saying, you know, using some of the motivational interviewing strategies, such as elicit, provide, elicit, decisional balance, giving him information regarding the benefits of reduction. Someone's saying work on the depression, so helping him manage the depression so that he'll be more likely to succeed in other areas of change. That's great. Some talk about CBT, great, which is helpful with depression, anxiety, and can be helpful with substances as well. Good. Other strategies like tracking, keeping diaries of the amount of alcohol or tobacco he's using. Right, and Shauna's really highlighting how you know, you can see how the mental health and physical activity and nutrition can all really blend together and make a difference. Susan's got a great question there. Can I talk to you about some lifestyle factors that might help you? So we all have a tendency to start, you know, you kind of hear of something that a patient might be willing to change, and we kind of jump on it and we get excited and we start offering them all these different opportunities and things that they can do, and really asking permission, you know, I have a couple of ideas, or I'd like to tell you about this. Would that be okay? That's so important. Great. So we only have a couple of minutes left, and I know that Leah has a couple of housekeeping things to address. I will stay on the line for a few more minutes if there's any questions afterwards. But otherwise, Happy New Year to you all. Thank you so much for joining us today. I hope this is helpful, and have a great afternoon, everybody.
Thank you so much, Rebekah. So just a few housekeeping announcements. So remember that a link to the learning assessment 2 will be sent by email. And again, we remind you to complete that in order to receive your letter of completion. And again, if you did participate as a group, please make sure to email Eleanor with a complete list of the participants by the end of today. As a reminder, we actually have our next Lunch and Learn webinar scheduled for next week, or not next week, coming up very shortly, Wednesday, January 22nd, and that is going to be focused on smoking and pain management, and our faculty presenter will be Dr. Peter Selby, and the application period is now open for that. Again, we'd just like to thank you all for joining us this afternoon, and a big thank you to Rebekah as well. So we have 1 minute or so. If anybody has any last minute questions, please feel free to type in the chat box. And again, thank you to all of those who joined via teleconference as well today.
Great. I think my email address might be.
It's on at the front.
Was it?
Yeah.
It would be at the very beginning, right? Oh, yeah. Okay, so I just realized that this is my old email address. So I will type in my current email address, and if any of you have questions, or if you had questions, the Teach team also has my contact information. I'd be happy to communicate with anyone if you'd like to discuss any information in the presentation. So I'll put my email address here. There you go.
Great, and we can distribute that as well.
Can you please provide us with the link to the study I was referring to? Sure, let me see. There's the reference there, Susan. And if you, I believe, nope, that's Teach Project, thebetterproject.ca. I believe there's some clinical tools there as well. So things like the bubble diagram. Diane, the session was recorded today.
Yes, and that will be emailed following our closure of the webinar. Eleanor will be sure to send all that information out to you guys. Yes, the links will, all the resources that were discussed today during the webinar will be sent via email as well. Okay, thank you so much for joining, everybody.